It is exactly 38 minutes past the hour. Welcome back to Sunday Live here at Citizen Television. We have in-house live Cabinet Secretary for Health, Susan Nakhumicha. We're going to be talking about the new shift to SHIF or SHA. In the meantime, Olive?
First, we take a look at what the Act provides where contributions are concerned. And salaried workers, their deductions will be 2.75% of their pay. As for those who are self-employed, their deductions will be made annually based on household income determined by a means testing instrument. I hear the CS laughing because she knows that question is coming. As for the poor and vulnerable, this will be from appropriated funds, prisoners as well from appropriated funds, and non-Kenyan residents who are in the country for a stretch 12 months and on will also be required to register.
That's a whole bunch of things to talk about. Madam CS, welcome to Sunday Live.
Thank you very much, Jeff. I'm happy to be here once again after we last met in Kisumu.
In Kisumu City.
Yes, yes. Glad that now we are in the real city.
So now we are literally at the registration stage, right? I mean, we're almost there. When is it starting? When does it roll out?
Thank you, Jeff. We are on the countdown. We now have 21 days to 1st of July. That is when we promised Kenyans that we shall be rolling over to the Social Health Authority. Now, we have people asking what is the difference between SHA, SHIF, and all the others. So the Act itself is Social Health Insurance Act, one of the 4 acts that were enacted last year in October. That Act establishes an authority, a body, called Social Health Authority. The body, the Social Health Authority, will be managing 3 funds. Primary Healthcare Fund, which we call PHC. It will be managing Social Health Insurance Fund, which is SHIF, and it will be managing Emergency, Chronic and Critical Illness Fund, we call ECCIF. Yes. So 21 more days, 1st of July. We begin registrations, and we expect that then Kenyans start to benefit from what we have been preparing all along.
One of the questions we received, Jeff, remember we posted online and we said, okay, so what are your questions? Was why can't it just be one fund? Why do they have to be 3 funds? I do understand that the Primary Healthcare Fund will be from appropriations. SHIF will be from contributions. Right. But why not just have one fund?
It's very confusing.
It is not confusing because what we want to do is to ensure ease of access, that everybody is able to access, but we also want to ensure sustainability of funding. The Primary Healthcare Fund, as you have rightfully said, Olive, it's from the government, it's government-sponsored. That is for level 1 of service, which is the community level, level 2, and level 3 of service. You are not expected to pay anything from your pocket. All you are required to do is to register as a member of Social Health Authority. Then we now have the fund where you are expected to pay a premium. That is the Social Health Insurance Fund, which is 2.75% of income. That is, you have to pay. Like if you are then referred from a level 3 service to a level 4, you must be a paid up member for you to access services. Equally, for you to access services at the highest level, like for example, in an emergency situation, if an ambulance has to take care of you, take you to a health facility, be stabilized in that health facility, you ought to have paid for your Social Health Insurance Fund to access the 3rd fund. So what we are trying to achieve, one is access. The other thing that we are trying to achieve is sustainability of funds. And the other thing that we are trying to achieve is to see then how best can we collect resources to finance healthcare.
Are there limits? Sorry, just a follow-up to that, Jeff. Are there limits? Because when I was reading up on the emergency fund, it said, you know, when you've exhausted your cover, is there such an occasion where you could exhaust your cover?
One, let me speak about what the package is. It is a benefit package expanded from what we have previously had in NHIF. Covers most of the needs that would be required. So you ought to move from one level of service to the other. For example, Olive, you have a fever, a cold, then you will go to their lowest level of service, which is a dispensary. That is level 2. You are not required to pay anything. Then once you get a situation that is serious and you are referred to a level 4 services, then you access benefits that are to a level 4 services. Previously, we have had situations where people who have critical and chronic illnesses, where they are told that now, for example, if you have cancer, you are told, okay, you have exhausted your benefits at the secondary level, therefore you are no longer on cover. And that is why we have come with the Emergency Chronic and Critical Illness Fund, that once at the secondary level, then you have reached a certain limit, then the tertiary fund kicks in. So there's no point where a Kenyan will be told that you cannot access services because you have exhausted your benefits. Yeah.
So if many of us right now are on NHIF, do we have to register afresh for this new funding?
Yes, we are going into a registration exercise that we expect His Excellency the President to launch anytime from now. And it is not, let me not say really as a fresh registration, but it is an affirmation of your details. And should they have changed, then this is an opportunity to change. So what has happened is that the data that we already have of Kenyans who are already on NHIF have already been uploaded onto the system. So this will just be an affirmation. For example, I key in my ID number, it brings me my name, Susan Nakhumicha Wafula. It confirms that this is my dependent. I'm able to confirm tick, 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 tick as I move up to the end of it. But if you are a new person, then you start the registration process afresh. But equally, we have made it as easy as possible. We have linked the system with the National Registration Bureau. So most of the data is already on the system. So it will be more of click, click, and confirmation of your details. Equally, if you have dependents that you have added, probably you are a family of 3 under NHIF, now you have added a baby, this is now an opportunity for you to add a dependent. Or for couples, if you had a wife and now you have 2, then you have an opportunity to add another dependent as a separate household.
That will most definitely get a lot of views. But so it's easy, let's say, for, you know, the 2.75% to come from myself or Jeff or yourself because we are on payroll.
Yes.
What about the self-employed? First, how do you determine what their income is to now calculate that 2.75?
Thank you. Now, as you say, it is easy for those on payroll because it's check-off from your salary at the end of the month. Your employer is expected to remit. We have people who are not in a formal employment, they're in self-employment. So they have an income. Of course, they know how much they make. So we have a tool, a means testing tool, which is a scientific tool that has been developed. And it is self-testing. It is you saying that this is me, I'm an informal setting, this is how much I make in a month, in a year, and therefore the calculation for my 2.75% will be this much. If you are not in any form of employment, but you have some sort of income, still you are doing self-declaration that this is what I have, and therefore there's a calculation of what would be 2.75% of your income. We have people who have zero income. Still, the tool will be able to, they should be able to declare, and the tool then determines that it's true, they have zero income, then they fall into the bracket that they need to be taken care of by government. So
this is the indigent and vulnerable?
Yes, the indigent
and vulnerable. But what if
they're
being paid cash on the side and they declare zero income? What are you going to do? I mean...
You know, Jeff, there are things that as a human being you can hide. There are things that you cannot hide. You cannot hide your economic characteristics, Jeff. If I look at the watch that you are wearing...
No, don't look.
I can do an estimate of what your income is. If I look at the earrings that Olive is wearing, I can do an estimate of their income without them telling me. So I want to speak to Kenyans and tell them there are things that you cannot hide. If you live in a grass-thatched house, you can't hide it. You are in a grass-thatched house. If you live in a tiled house, you can't, there are things that you will do and somebody will know that as much as you want to look like you don't earn, this is your level of income. So there are those characteristics, economic characteristics, you can never hide them as a human being.
But you're saying this is self-declaration.
Yes.
Of course, I want to pay less.
We have inbuilt mechanisms into the self-declaration. There are things that you do. And you see now we live in an environment that is almost digitized. I can bet that most of the time now you don't carry cash on you. No. You do most of your transaction on M-Pesa. So I can tell how much you are able to...
I might
switch back to cash.
You might switch back to cash. I'm telling you, it'll be so... You're already used to and accustomed to a certain lifestyle. You know, and when you are switching to cash, there are points that you'll need to convert or you'll need to collect this cash from somewhere. isn't it? You just don't keep money in your house. You may need to withdraw from an ATM. That information, if it is looked for, it is available. So I want to speak to Kenyans. You don't have to hide. This is your health. Please take care of your health. Declare your income yourself. We'll tabulate, the tool will tabulate the 2.75%. And what we are promising is a consistent benefit package that everyone is going to benefit from. So do not lie about yourself, because when you get into a problem or when you get sick, you'll expect to be taken care of. So if you did lie, who will take care of you? Yeah. Okay. And if everybody lied about their income, so then what happens? I think as a nation, this is now a time that we get into a space, we speak truth to ourselves. Yeah.
Okay, we have lots of questions from folks out there.
Yes, we do. A lot of questions came in. I told you during the break that a lot of them were from healthcare workers. But before we get into that, this is Mrasta Muislamu who is asking, just asking kama Mkenya, NHIF many have been paying for years. Iyo itapotea hivyo?
NHIF, they actually pay annually. So what we'll do is a rollover. And as I have said, we are doing more of confirmation of status. So if you have paid, and based on the assessment that is done of your 2.75%, you have an extra, it is moved over to your account. If you have less, then you're asked to top up. If you have nothing, then you have to pay up. Nothing is going to get lost. This is a digitized system. Yeah.
A lot of people are asking if I'm paying my contributions. Does my wife and kids, are they all covered under my own contributions?
We have a payment for a household, the income of a household. You have income, Jeff, your wife works, your income together, 2.75%. Once the member has paid, you know, for insurance, we talk about member plus. So once the head of the household has paid, it covers everybody else under that household. Yeah.
And there's a deficit, there were stories that have been running, right? So rural private hospitals saying NHIF owed them 29 billion shillings. Two questions from that. What is the status of this debt that they claim NHIF owes? And number two, how will the claims management change with SHA to make it more seamless?
Thank you. I think that is a while back when the figure was
March, I think it was.
Yes, when the figure was at 21 billion. We have been releasing payments. And by the way, Olive and Jeff, payment of claims is a continuous exercise. Tomorrow you will be owed 10 billion. The next day we have paid, you are owed 2 billion. You provide services, it goes up and down. So we have been paying. Just last month, the total release was about 9 billion total in terms of payment. So we have been trying to clear as we move by. But again, there is no loss of what has been invoiced already. So long as the invoices are reconciled, that this is the true status that we owe you this much money, that is going to be rolled over into SHA. So SHA is going to take
and
assets and liabilities of NHIF.
And there's no stopping this. I mean, this will roll in.
It will roll in. By the way, our plan is that as a Kenyan, you should not experience any change to show that there's difficulty in moving from NHIF to SHA. We want it to be as seamless as possible. And that is not to say that we may have hiccups. We may have hiccups here and there, but we have teams out there that are prepared to handle any issue that may arise.
Okay, this question, can I go ahead, Jeff?
Go ahead, please.
Michael Obonyo, who wants to know, how will the implementation of SHIF affect the comprehensive medical cover for civil servants that was being provided for under NHIF? What alternative arrangements are being made to extend the same comprehensive medical cover for civil servants?
Allow me to explain. One thing that made NHIF not to operate optimally was the existence of enhanced covers within one cover. So we had many enhanced covers. We had National Police Service cover, or Teachers Service cover, or this cover, and this cover, and this cover. So what we have done now is to work on the benefits package, expand it, so that then it is able to cover the things that were primarily covered by the enhanced and not the essential benefit package that was there. So essentially, then there would be no need to have a comprehensive cover, or we are not going to have other schemes within Social Health Authority. However, that does not stop an employer from having other insurance covers. If Royal Media determines that we have looked at this essential, the benefit package that is being provided by Social Health Authority, we feel our employees need much more than this, they can go to a private insurance and enhance their cover.
And we'll have two covers?
No, but yeah, because if I have private insurance, why do I need...
Yeah, sure.
This is mandatory. This is a social health insurance. And that is why I'm saying if employers need to, but what they need to do at the first instance is to look at what is the benefit package. What is it covering? And I want to assure Kenyans that this is almost comprehensive. Yes. And for once, we are going to equalize access. That then there is no Jeff, and there is no cleaner, and there is nobody. We are all accessing the same benefit package.
Sounds like socialism. Well, that's just me. Madam CS, Leon Lidigu says, as Kenyans wait for SHA to roll out in 21 days, currently some are unable to access NHIF right now. Why?
Leon Lidigu, I think I spoke to you last week. He's a reporter from Nation Media. We have hiccups with NHIF, and we have had hiccups for a very long time. And those are some of the reasons why we are doing the reforms that we are doing. But I want to assure Kenyans, you are supposed to access your services at NHIF and to plead with service providers. There is no need for tension. There is no need of thinking of how it is going to be. Please provide services. Once you provide services, your claims are verified and reconciled, you will be paid. Because I know there's that tension that people are expecting that with this rollover, maybe we will not be paid. I want to assure them, so long as you have provided services to Kenyans, your claim is legit, you will be paid for what you have provided. And
I'm curious about that. What is the process of selecting service providers? Because NHIF, there were accusations of collusion between NHIF and health service providers. So what is the selection process like? How transparent is it?
Last week, we finalized on our tariffs. Tariffs is what shall be payable. You know, for now, we are putting everything out in the open for people to see. So on Monday, we are going to put that, which is tomorrow, we'll put that in the newspaper, so that we go into a phase of public participation by the service providers on the tariffs that we have developed. Once we finish with the public participation on tariffs, we're able to agree and gazette them. Those become the tariffs applicable. Then the next thing is empanelment of service providers. It is going to be a competitive process. Can you be able to provide this tariff or not? So the issues that used to be there in terms of collusion, they are not going to be there. Besides that, last year, we did a health service survey. So we know how many facilities we have at level 2, at level 3, at level 4, at level 5, and level 6, and what kind of services are they able to provide. That we already have in a document we have gazetted. So we shall be matching and mapping. If you say that you can provide these services, we look at our report that we did last year. Does that match with the report that we have? Did we see a theater in your facility? How many did we see? Did we see health workers? How many nurses did we see? How many doctors did we see? Therefore, are you able to provide the service that you are claiming that you are able to provide or not? Yeah.
A lot of patients these days, we're hearing stories about cancer patients. And you know the cancer fees are so high.
True.
Is this going to be able to cover for the most part?
Yes. And this is, again, in these reforms. Previously, there are some tests that were never covered by NHIF. Now they are going to be covered by the Social Health Authority. All the tests are going to be covered. Previously, there was a limit as to how much you can access. Like if you are a cancer patient, then you're told maybe you can only do therapy twice a week or 3 times a week. This time we are saying there is no limitation, because once you have exhausted what is within the social health insurance, then you move into the emergency, chronic and critical illness fund. And that's why it is very important, even as we start this budgeting process, I have talked to the members of parliament, we must have funds for emergency, chronic and critical illness fund, so that all those patients that have cancers, the critical illnesses, then they can be taken through that. But I also want to tell Kenyans that the best thing is to prevent some of these cancers. For example, we have the HPV vaccine for girls that then prevents cervical cancer. It is better for your girl to get the vaccine rather than wait for them to get the cancer. Number two, the community health promoters that we have put in place. Should you have any issue, then we should be able to identify most of these cancers early. Because what is happening is that most Kenyans, by the time they get to a facility, they're already stage 4 of the cancer, very progressed. Then it becomes expensive to manage it. It takes a lot of time to manage it. But most of this, if they are discovered early enough, then it is less expensive to manage, and probably the outcomes are better than they would be if it is diagnosed at a very advanced stage.
The other day I saw you in Bungoma after the Madaraka Day celebrations. Remember, you were dressed in the Luko Kimba.
Mimi ni mama wa kanisa.
Ni mama wa kanisa hivyo, nilijua hiyo siku. But part of what you addressed was Linda Mama. And there have been concerns around Linda Mama and Eduafia. Your response to that?
Thank you. I want to clarify. I have been saying it, but I believe this is a better forum, and maybe more people will be able to listen to me. Linda Mama was covering a woman, childbearing, who has already declared themselves that they are expectant. So that Linda Mama would start at, I think, where it would cover for you to access 2 sessions of clinics before delivery. It covers your delivery and covers for you another 2 sessions after delivery. Linda Mama cover ends there. So what happens? This is a mama who has needs beyond maternity needs. This is a lady who has delivered a child who requires health services. So what we have done is that now, hatufanyi Linda Mama, tunalinda jamii. Once you pay your social health authority, then it covers you both for the reproductive health, which is Linda Mama. It covers your child who may need medical services. It covers your husband who is meant to be healthy, working and providing for the mother and child. So tunalinda jamii. The benefits are not lost. Let me also clarify. We had orphaned and vulnerable persons being covered independently as an enhanced cover in itself. That has now been put under SHA. That once we have people paying, you have paid, then you are covered. These people who are not able to pay, then government is going to pay their premiums. So the orphaned, the vulnerable. We had old and persons with disability who are not able to pay themselves. Government is going to pay. We had indigents, people who have no income at all, the poor. Government is still going to pay their premiums at the minimum, which is the 300 that was set. Yeah.
All right.
Equally, Eduafia. Eduafia, what it was doing, it was covering the student. We recognize that a student comes from a household. They don't exist on their own. So what Eduafia was doing is that it governs the student at school. And I want to say that for sure that scheme was being misused. And yet, I am sure even you, Olive, while you are at school, if we start to count the number of times you attended hospital, there are very few. That is a very healthy population. So what we have done, instead of just covering the student, and you leave their parents in distress when they are sick, is to cover the whole household. So this household has a cover for the whole family. Whether the child is in school or not at school, they are covered. So for me, I want to tell Kenyans, please pay your social health authority. It will cover the household. The children who are in school will be covered. The mother who needs reproductive services will be covered. The man who may need any other services will be covered.
Bottom line. Sorry.
Even the Auditor General's report actually did flag that misappropriation of funds where Eduafia is concerned. Sorry, Jeff, I wanted to ask if it's okay to take a look at some of the questions that came in from those who sent in their questions. Yep. And as I mentioned earlier, lazima nikuulize clinical officers. They say that you have not met them once since they started their strike, and they have been on strike for what, about 70 days, is it?
That's right.
And let me see if this is one of those questions. Yes, this is Felix, and he asks, clinical officers form an integral part of primary care. What's the Waziri's approach to handle their grievances, which include enhanced risk allowance? I think several of these questions are related, so we can just look at a couple more so that she can answer them at once. This is Boniface Mbaka, who says, tonight, as you talk about SHIF, can you also tell Kenyans steps you have taken to ensure poor Kenyans have the much needed services of clinical officers who have been on strike for the last 70 days. This is Kijana, and he says, I have been paying NHIF for so many years. How will I transfer my NHIF card to SHA? So that is different, yeah? That has to do with the card.
This is Himwa Washa. It says, let her settle the clinical officer strike. Outpatient services and surgeries are paralyzed. Whatever efforts they put to dig deep into our pockets should be reciprocated by quality services from well-remunerated health workforce. And Kidse says, please ask, what is the fate of UHC and CHIRP project staff whose contract has come to an end? One more. V. Kavungwi says, can the CS take us through the process? And if one needs to be registered as a SHIF member, is it a process that one can do herself, or we have to visit NHIF headquarters? I think we spoke about that, but most of that you've mentioned. But yeah, you can.
Okay. Thank you. Let me begin with the one for the clinical officers, the issue of risk allowance, and that they have been on strike for 70 days. One is that this government, Kenya Kwanza government, previously the Ministry of Health had one state department. But in this government, there was a deliberate effort to create a state department for public health and professional standards. That is headed by PS Mary Muthoni. So that should give them some level of comfort that we recognize that health workers, health professionals are important and integral part to achieving universal health coverage. One of the 4 pillars of universal health coverage is health workforce. So we have been working on each of the pillars. I want to say that on the health workforce, we have not done so well, but we know that we have some work to do. On clinical officers specifically, I know and I'm aware, even last week, they met the principal secretary. And it is only after the principal secretary has escalated to my level that I'm able to handle it. But the issue that they're asking about is risk allowance. Currently, they earn a risk allowance of 3,000 shillings. They are asking for an increment to 15,000 shillings. Now, I know there is talk that we just need to take care of the clinical officers who are at the national level, who are less than 200, working in the national referral hospitals. Because, you know, health is devolved. So majority of these clinical officers work within the counties. So once we look at the enhancement of the risk allowance, in fact, from 3,000 to 15,000, what percent is that? But we have to look at it in totality because it will affect all the clinical health officers in the country. So what they need to do, and I know PS Muthoni has given that. I have personally talked to their chair. He's called who? I've forgotten his name, but I have talked to him about this thing. I've said, this discussion really, first have it with the COG, Council of Governors. Can they afford this jump of 3,000 to 15,000? At the national level, if we make it a policy, ours, and which we have already done, and they know, they are aware that a letter already came from the Ministry of Health, from the State Department of Public Health and Professional Standard to SRC regarding this. And SRC's feedback is, can you afford it? As national government, based on the numbers that we have, we can say, yes, we can afford. But is that what we want to do? No. We want, if a risk allowance is going to be enhanced, it should be for all the clinical officers. So what we are waiting is finalization of the discussion with the Council of Governors. Once they agree, then that should be easy for us also to say, okay, then resources must be put together for them to get the increased risk allowance. But maybe just from a point of caution, 3,000 to 15,000. That is a huge jump. I think they should be a bit come down to a discussion with the PS, who has the full mandate to discuss this matter with them, and also think of a figure that can be afforded, a figure that is sustainable. Because they're not the only ones getting a risk allowance. All health workers, a number of them get the risk allowance, especially those who work with direct contact with the patients, they get that risk allowance. So they should know that we have not forgotten about them. We are aware, but we would like this conversation to be driven by Council of Governors, which is their primary employer. Then once that discussion is agreed, then we do what we need to do at the national government.
Sijui kama Peterson Wachira, swali lako.
Peterson Wachira, that is the name that I was looking
swali lako limejibiwa.
Yeah.
But really quickly on the issue of, can I use my NHIF card and the registration, do I have to go to NHIF headquarters?
Before I respond that to Olive, let me respond to the issue of UHC workers. We had UHC workers who had a contract that lapsed. When this government came to office, we had a discussion and negotiated together with the Council of Governors, all governors at a summit. And the summit did agree, and a resolution was taken that their contract be renewed for 3 years. However, when the ministry wrote to Public Service Commission to renew it for 3 years, Public Service said, no, we'll renew for a year. So they got a renewal for a year that ends in May, that ended in May. However, before the lapse of May, we have been having conversations, and Public Service Commission has said, okay, renew for the other 2 years. So there is going to be a renewal for another 2 years. But I want to say that I am keen on this. Ideally, they have already provided services for 3 consecutive years, 2 terms, that is 6 years. They ought to be permanent and pensionable. But now that is a conversation based on availability of resources. So they need to take the renewal that they have been given for another 2 years. But during this period of time, then we should be able to make a determination. If this is a workforce that we really need, then they need to be absorbed by the counties, because they provide services at the county level. So they need to be absorbed by counties. The process of registration for SHA, we have simplified it as much as possible. Largely, the biggest channel for registration for Social Health Authority is going to be yourself, because it is a digital registration. If you have a smartphone, a Mulika Mwezi, the one that is not a smartphone, will tell you how to register. If you have a smartphone, we'll tell you how to register. If you are able to access the internet, we'll tell you how to log in and register. If you are unable to register, community health promoter will be able to register you. Remember, we have deployed over 100,000 of them. If those are unable to do it, you can register at your nearest Social Health Authority office. You can also register at your nearest Huduma Services office. We are going to have a number of channels where one can be able to register. The only thing that you may need to visit your health facility for finalization is to take the biometrics.
Mm-hmm. Yeah. Madam CS, my good friend at the Nairobi Stock Exchange, Kiprono Kitoni, he says you've explained very well and you should have more of these forums, just to break it down to Kenyans. Mm-hmm. He also says that maybe you should put some of the funds in the Nairobi Stock Exchange to get some gains. Don't answer.
I'm not sure whether government trades at Forex.
There was that last one. Can people still use their NHIF card? Once SHA rolls out.
Is in place until we communicate. Still continue using your NHIF card until we are able to say, now this is the end. But we want to make it as seamless as possible. So we are likely to have an overlap for some time until we settle into Social Health Authority. All right,
Health Cabinet Secretary Susan Nakhumicha breaking down the move from NIF to SHIF and SHA.
Mm-hmm. Where are you getting NIF? It's NHIF. Or the H is silent.
No, he's trying to the shifting with silent. NHIF. Is like the, yeah.
Should I say no?
Well, good thing you answered the UHC workers, because then they would have had our necks.
You know. Mm-hmm. Thank you so much for your time. We appreciate it.
Thank you.
We're going to take a break, come back. Plenty more ahead, including our weekly feature, Citizen Planet. Stay tuned for that. Keep tweeting at Kwenanga Jeff.
At O Barrows, at Citizen TV Kenya, hashtag Nazoya, Sunday Live.
Sunday Live takes a break. We'll be back in a moment.